Hi, I'm Graham and I'm here with Matt. We are the co-directors of the London Centre for Applied Psychology, and we've been looking at the evidence behind addiction. In part one, we looked at the evidence behind what causes addiction and what influences whether someone becomes an addict and some of the definitions behind compulsive behaviour and addiction. But in this part, we're going to be looking at the clinical implications of working with people struggling with addictions. And Matt, again, cognitive behavioral therapy is the psychological treatment of choice recommended by the NHS and the National Institute for Clinical and Health Excellence. How come CBT is highlighted as the treatment of choice for working with addiction?
CBT says that addictions, including behavioral addictions, arise via dysfunctional, deeply ingrained thought patterns. So negative thoughts undermine your efforts to make healthy choices, and negative beliefs can stem from childhood coping mechanisms that are no longer functional to you, but are nevertheless deeply ingrained. So by acknowledging those beliefs, you can change your thinking, you can leave destructive patterns in the past, and you can take steps towards recovery. So that's CBT as it relates to addiction in a nutshell. And I guess so you can see there, it's a pretty compelling way of getting straight into the problem and offering some kind of relief. And of course, CBT has got that evidence base which tends to go far beyond other therapies. So I think it's got a kind of compelling rationale. It's trialed in many other areas of psychological distress, and it seems to have a convincing evidence base and rationale for understanding the problem and then moving through to at least the beginnings of a solution, even for a problem as sticky and grippy as addiction.
We should be clear, though, it's not the only thing that works with treating addictions and working with addicts, is it?
No, absolutely right. So, I mean, before talking about those specifics, it might be worth just talking about some principles.
Yeah.
And in the online training that we provide, we suggest 5 principles which are drawn from the evidence of what works. And there's roughly this. So the first is to sort of think, read, or watch your way in. So if you're not an addict, it's difficult to think like an addict. And that's actually a good thing, but it also carries a bit of risk with it. So you do need to know the addict's world. So in the training, we list a bunch of films and books and podcasts and things like that you might want to take a look at. And the second principle is it's just not to rush to refer on. So this point really follows on from the first, and it's really a reminder to remember that there are so often co-occurring mental health problems with a problem like addiction. So the average therapist or counselor is actually likely to be better trained in dealing with those often known as comorbid conditions, much more likely to be well trained to do that than, say, a specialist drug service would be able to do that. And the evidence also suggests that providing those specialist services, those who often themselves have recovered from addiction, who are providing those services, actually do know better working with addicts than those who've never experienced addiction for themselves. So it's a slightly counterintuitive finding. The fact that somebody has themselves recovered from addiction doesn't make them a more effective counsellor or therapist than somebody providing the same intervention who hasn't themselves experienced or recovered from addiction. And I think if you are taking those cases on, if you're thinking your way into it, you're trying to understand the addict's world, you're not rushing to refer on, and you're willing to work with addiction, then you probably need to draw on all of the community resources around you, because addiction is a sticky and, it's an incredibly difficult habit to dislodge. So you're thinking about the client's friends, you're thinking about their family members, you're thinking about the GP, you're thinking about things like 12-step groups. And I guess in terms of just rounding out the principles, the fourth of those principles is adopting quite a strong stance. So sympathy isn't going to be enough in this instance. I think you and I are sometimes skeptical of whether sympathy is enough in other circumstances as well. But in this instance, it's really probably pretty clearly not enough. Like, listening is not going to be enough. You're going to likely need to begin the process of teaching social skills and coping skills, for example, and you're going to be thinking about negotiating abstinence periods with the person who is in addiction, and you're going to be thinking in really practical terms about how and when they attend group work, whether they go along to a 12-step group, when is the first time they do that, what time, who's helping them get there, those sorts of really practical things. And then the final point sort of brings us full circle almost. The final principle really being to follow the evidence.
Great. So let's dive into a little bit more into that evidence. We've talked a bit about cognitive behavioral therapy. NICE also suggests some other what are called third wave CBTs, such as ACT, or acceptance and commitment therapy. You see some similarities to the 12-step programs here, right? In ACT particularly?
Yeah, I think so. I absolutely do. So acceptance and commitment therapy, as you'd guess, even if you don't know that particular type of therapy terribly well, is all about acceptance, unsurprisingly. And that really is the premise of the 12-step program too. So step one in the 12-step program is accepting our predicament as addicts. So in either model, and in fact, in any model of change, you're going to have to learn to accept your feelings, your impulses, your cravings, and accept that you can't control them, or that the way you have previously controlled them, for example, controlled your feelings with alcohol, controlled your feelings by trying to sedate them, it just hasn't worked very well, to say the least. It's not only an ineffective control strategy, it's also now part of the problem. And there are many other similarities too, but we probably don't have time to get into them. But I think that's the primary way in which those programs feel, those ways of intervening feel similar.
Is one of the differences, we talked about similarities, but is one of the differences that distinction between complete abstinence against harm reduction? So would ACT, acceptance and commitment therapy, focus more on harm reduction as an outcome, and 12-step focus more on abstinence?
Yeah, I think that's fair to say. I think that's probably right. So although abstinence continues to be thought of by many as the benchmark in terms of outcomes, there are other outcome variables that have started to come into wider use. So partly because abstinence in truth is often not the outcome, even of successful treatments, is a very, very high bar. And as a consequence, reduction in consumption or behavior and enhancements in the quality of life have tended to become more widely used as the measures of outcome. So we might say that they permit a more fine-grained reflection of differences in treatment impact than those very categorical variables such as abstinence on the one hand or non-abstinence on the other. So I think 12-step recovery nevertheless continues to aim for abstinence, but other programs, and ACT is one of them, would be looking at harm reduction as a legitimate measure and actually a significant marker of success.
The 12-step programs come in for quite a lot of criticism in recent years. So talk us through the evidence around the 12-step program. Does it work?
So there's a bit of research, older research now, called Project Match, which people may have heard of. It's basically the largest RCT, randomized control trial of alcohol treatment ever conducted. So it's a large number of people in that group, about 1,700 from memory, examined the efficacy of 12-step treatment compared to motivationally enhanced therapies and CBT as the kind of accepted gold standard. And in terms of what it found, so patients in 12-step treatment were significantly more likely to remain continuously abstinent than patients in the other treatments, and by a difference of around 11 percentage points. And that effect persisted even as long as 3 years after treatment. So there are some limits to that study, as ever. But the notion that 12-step has had its day, or it's a relic of the 30s, or it's cult-like, really way off the point, to be honest. It's the world's biggest support group by far, and for a reason. You know, there are more than 150 meetings of Alcoholics Anonymous, for example, in London on any particular weekday, and it's free as well.
Yeah. What about residential rehab, places like the Priory? I'm sure people watching will have seen kind of celebrities going there. So if you can afford it, surely that's got to be the best option, right? You've got everything under one roof. You've got 24/7 care, you've got medical support, you've got therapy, you've got group work. Surely that's the best place to get clean, isn't it?
I think it's an interesting question, that, isn't it? I think that would be the assumption. I mean, truthfully, I think the jury is out on that. So the National Institute of Clinical Health Excellence acknowledged the need for more research into that question of whether residential treatment is associated with higher rates of either abstinence or a reduction in drug misuse than community-based care. And community-based care is often based around the 12-step program. So I think the summary of that is, honestly, we don't currently know. And the price difference at somewhere like the Priory and what you'd pay in a 12-step program, which is a voluntary contribution. A pot is passed around, and you might put £1 in, you might put £2 or £3 in, and very seldom would you put much more than that, or would there be an expectation that you would? So I think the Priory is about 20 grand a week. I wouldn't want to be quoted on that, but I think that was about right. The last time I looked, there's a place in Switzerland, the name of which I can't remember, which is about 4 times that amount. So, I mean, you can spend a fortune on residential rehab. Some people, I'm sure, will swear by it. It's where they did their recovery. It's how they got clean, and every penny they spent will probably be worth it. But the interesting thing about those treatment programs, even at a place like the Priory, for example, they're basing their approach very much around a 12-step kind of treatment model.
So a lot of which you can get for free anyway, pretty much. All right. So in the workshop, the training that we have at LCAP on addictions, you go through a framework of 10 clinical implications for how to work with addictions. We're going to try and whiz through them together, Matt, in about 90 seconds. So 10 implications in 90 seconds. Obviously, we take quite a lot longer than that on the training itself, but you start with number 1.
So drug use is chosen behavior. So we shouldn't view drug users as individuals who are incapable of choice.
Number 2, we encourage you to view addiction as a chronic and or relapsing condition. So adopt a long-term perspective on change and maintenance.
The third one is that client motivation is key. So client readiness to change is associated with greater treatment success. So I think that's a finding which crosses the board, but it's particularly apt in terms of addiction.
Number 4, the therapeutic relationship alliance is crucial. You've got to aim for accurate empathy as much as possible. That involves adopting a strong stance, but don't confuse that with confrontation, which can put clients on the defensive.
Fifth principle is that addiction doesn't occur in isolation. So we're talking about treating the whole problem, and treatment may not be effective unless you're involving others who support the change. So that's family, friends who are living a drug-free life, for example.
Number 6, and directly related to that one that you just went through, Matt, coping skills and social skills are essential to recovery. The most important initial social factor is having close, positive relationships with people who are not using drugs. So to achieve this, be ready to teach social and coping skills with the people you're working with.
Number 7, the drug problems don't occur in isolation. I think maybe a statement of the obvious, but they're usually accompanied by one or more, perhaps I should say, other mental health conditions. So be ready to deal with those as well.
Number 8, where you can kickstart recovery via a period of abstinence. Even long-standing addictions can be interrupted via a short initial period of abstinence.
And number 9, long-term change involves finding alternative sources of reward. So organizing treatment around developing meaningful, rewarding, and a more fulfilling life, establishing social connection. And one of the ways in which 12-step programs really work is it's a community of people who provide readily available social support. It doesn't have to be that, but it's one good, obvious, readily available example.
The final one, number 10, motivation isn't static and relapsing is a fact. It's likely to happen, so work with it. Clinical trials support the use of motivational interviewing that can help evoke a client's own statements of desire and their commitment to change. Some of the stuff that you were talking about, Matt, about acceptance and commitment therapy as well, and that acceptance and commitment from the client themselves.
Absolutely. Whistle stop tour.
Yeah, quite. Throughout the training, you give examples of how to use those 10 principles. So if people do want to know more and think about how to apply those ideas with their own clients, they might want to take a look at that course. We'll give the link below these videos.
Yeah, absolutely. So, I mean, like all the training that we're offering, we've tried to make it really practical and include ideas that you can start using straight away.
Great, Matt. We've done a bit of a whistle stop tour through the world of addiction. Last word to you. Sum up those 10 clinical, practical ideas we've just talked about, if you would.
Yeah, let me try. So I think addiction is really just a particular example of an age-old psychological problem, which is something like, why do we persist in patterns of behavior that lead to harmful consequences? Addiction is just one example, it seems to me, of the trade-off, the tension between immediate gratification and our long-term welfare. And similar underlying vulnerabilities could emerge as addiction in one person, or as depression or anger or anxiety in another. So the principles and the framework for intervention that we've looked at, and which we talk about much more in the training, that really can and does apply to a broader range of human problems. I think in the end, it takes us back to the conclusion that you and I often come to, that good therapy has an awful lot in common, and that all good therapy actually looks quite a lot alike.
Okay, if that's been helpful to you and you want to know more about addiction and how to work with addiction, head over to our website, which is lcap.co.uk. That's lcap.co.uk, or click on the link below this video for the specific training on addiction. Matt, thanks for your time today.